everybody, for your patience here. For the fellows, just ahead of time, if a lot of these slides look familiar, I'm going to give my apologies. I think when we scheduled me talking about enteral nutrition and defined diets back in May, I then realized that we had this talk fairly close back to back, but I think there's enough of an audience here that hasn't heard that talk that we'll still go through things. And I did make some changes to the previous talk that I gave. So this won't be so much case-based, but just an overview of both defined diets, exclusive enteral nutrition. And you know what? And I think I'm just trying to see if this is actually the right version. Whitney, I don't know that this is. Whitney, I think this is not the version.
Okay.
This is not my newest. Yeah. So I sent some. Is that what I just sent you right now?
Mm-hmm.
All right.
This seems to match what was attached to the chat.
Okay. Got it. You know what? I think I realized I had switch this a little bit more because I was just looking at the title. I'm going to try to send this once more, and if not, we can go with this slide set because I did put in more updated references.
Gotcha. Okay.
Sorry about that.
Sorry, you're right. The title isn't the same as in the.
Right. Yes. Worst case scenario, I can just give it from the handout here too. So.
Okay, I got the new one. I'll
Awesome. Thank you.
What is your new title? Because this is the same. Oh no, wait, it is a little bit different. Okay.
Yes. You know me. I'm a little OCD, so this is also
And Lexi has updated photos.
Yes, that was the most important thing, better headshots. All right. Okay. All right. So are the slides loading? Yeah.
Yeah, but it wasn't giving me the option to switch it. Oh, here.
All right, perfect, great. So now that I've taken up this much time, so I will try to get through all the slides here. I may not give you the pop quiz. So we thought we would talk about exclusive enteral nutrition and defined diets. And I suspect that most of you all are very well versed and have probably heard different permutations of this talk from other folks in regards to how we look at diet in IBD, specifically Crohn's disease. And so my hope was to go through some of the different areas. And so we'll go through some of the objectives that I hope that we can cover. Oh, good. So I can actually control this. Perfect. So we always have to talk about disclosures. For those of you who don't know me well, and there are very few of you, I am absolutely totally wedded to the welfare of my dog. But I do want to do the disclosures that while I don't eat a CD-like diet, my dog probably does. And yes, this is actually a meal that I have prepared for her. I don't do this on a daily basis, however. And so for the purposes of this talk, I just wanted to go a little bit through the history, both epidemiologically and pathophysiologically, about the impact of diet on inflammatory bowel diseases, specifically Crohn's disease. And then we're going to talk a little bit about the concepts of nutritional therapies in IBD, including the efficacy, how well we can administer, talking about exclusive enteral nutrition in Crohn's disease, and specific defined diets, which to date really have focused more on Crohn's disease than ulcerative colitis, although they have been used in both types of inflammatory bowel diseases. And then a few thoughts that I have on approaches to practical implementation. And finally, the pop quiz, which at this point we may not have time, but just some questions that I wanted to sort of have you all think about as we think about utilizing nutritional therapies. And so some of the questions for the group that if we have time, I thought we could have a quick discussion at the end. Thinking about this in the context of having discussions with your patients, how you would approach discussions on diet in the context of IBD, both in terms of treatment, as well as how diet impacts the development or maintenance of inflammatory bowel diseases. When you talk about exclusive enteral nutrition, how you would consider explaining your choice of formulas to both patients and their parents, especially with some of the data that we're going to talk about in regards to the different components of your diet that can be more pro versus anti-inflammatory. And then thinking about some ways that you have been able to sort of really encourage your families to consider different types of dietary therapy, you know, along the lines of motivational interviewing, motivational psychology, you know, modeling behaviors, giving practical tips. And so I'm just going to give sort of a brief overview of a Venn diagram that many of you may have seen. But when we talk about inflammatory bowel diseases, you know, one of the things that I know we always sort of think about when we sit with their families is to talk about the different things that come together that lead to the development of inflammatory bowel diseases. So we know that it's not one thing or the other. And I know that we often say, okay, there's got to be that genetic susceptibility. And when we think about it, though, that in itself makes it already quite complex. When you consider that there are over 240 genes that are associated with different aspects of the development of Crohn's disease, when you think about like barrier function, bacterial killing, immunoregulation. But we know that it's not just about genetics, because if it was about genetics, then our patients would be diagnosed much earlier in life. And so then we have to look at the interplay or the impact of the changes in the commensal microbiota, environmental triggers, and subsequently that dysregulated immune response in different aspects of immunity. And so we have a lot of environmental triggers. We could devote a talk to each one of these. For the purposes of this talk, we are going to focus on diet. And so when we think about diet and risk, you know, folks have looked at different aspects of our diet, both the protective and the inflammatory. And this is just from a meta-analysis from several years ago, where a group of investigators looked at all the different studies that looked at the impact of soluble fiber. And the bottom line from their review, looking at the different studies, is that diets that are higher in soluble fiber really do lead to a decrease in Crohn's disease. So I think looking at this even further from an epidemiologic standpoint, we know that the group, Ananda Krishna's group, looking at the National Nurses Study, has really looked at the protective aspects of a diet. And I know I presented this before, so I'm just going to go through this briefly. But one of the first studies looking at the National Nurses Health Study was looking at what they called a Prudent diet score. So basically, this Prudent diet score looks at what's considered the healthier components of a diet that would be less inflammatory. So diets that are higher in things like fish, fruits, and vegetables. And what they found is that the women that were in the highest quartile of these Prudent diet scores during their high school years had a greater than 50% lower risk of developing Crohn's disease, but it didn't impact ulcerative colitis development risk. And so when they looked at the different components of the diet, when you look at statistical significance, fish and fiber were sort of the big pieces. So then the other things that folks have looked at, the flip side, are then the inflammatory components of a diet. So saturated fats are a big piece that have been seen both in animal model studies as well as epidemiologic studies, and specifically looking at mechanisms, perhaps the impact on intestinal permeability. Do you have increased mast cell activation? But interestingly, when Lindsay Elbenberg and colleagues from Penn and the Carolinas had looked at the impact of red meat consumption, they did find that that in itself was not associated with the increased risk for developing IBD. So then more recently, the same group that looked at the Prudent diet scores, so the group from Boston, looked then at what they called an Empiric Dietary Inflammatory Pattern Score, or EDIP. So basically, they're looking at the diets that are the opposite of the Prudent diets, or the development of the Prudent diet score. So the way they developed this EDIP is to basically, through linear regression models, the team had looked at different food groups. So they had 39 predefined food groups, but the EDIP was based on the foods that were most likely to lead to an increase in C-reactive protein, interleukin-6, which is an inflammatory cytokine, and TNF-alpha, which is another inflammatory cytokine. And basically, the higher your score, the more inflammatory your diet. So looking at this piece, they found that these higher EDIP scores were associated with a higher BMI and lower physical activity. Not completely surprising, but again, they found this. And what was interesting is that when you were in the highest EDIP sort of quartile, you had, again, a greater than 50% risk of developing Crohn's disease. So it was the opposite of what happened if you were in the highest quartile of your Prudent diet score, where you had a significant decrease in the risk of developing Crohn's disease. And again, interestingly, there was no significant impact on the development of ulcerative colitis. So then they did a sub-analysis and looked at the phenotype of Crohn's disease that may be most affected. And so they found that there was the greatest association when you had a high quartile EDIP with the development of ileal Crohn's disease. You also did have increase in both ileoclonic and colonic Crohn's disease, but not to the extent that you found with ileal Crohn's disease. And again, this makes you sort of think about our own approaches to dietary therapies in patients with Crohn's disease. I think that's one piece. And then the other piece is the more colonic predominant your disease, the less of an impact. That goes to sort of our thoughts that it's not just UC and Crohn's disease being two discrete disease entities, rather than the probability that really inflammatory bowel diseases are more on that spectrum, and that more colonic predominant Crohn's disease is most likely more similar in many aspects to ulcerative colitis than ileal only or small bowel or upper GI tract disease in general. So thinking about different things or different components of your diet that can really cause the inflammation that we see in IBD. There was the IBD research group from Georgia, from Atlanta, that had looked at different components. And one of the things that they looked at least animal models of colitis was the impact of emulsifiers. So things like polysorbate 80, methylcellulose, and did find that emulsifiers increased gut permeability. So you can see with the methylcellulose and the polysorbate 80, you can see that there was significant increase in permeability. And what they were basically looking at when you look at this sort of busy graph is when they say the distance of bacteria from the intraepithelial sort of cells, the closer you are to the epithelium, if you're between bacteria and the epithelial cells, the greater the permeability. So basically, you've lost that protective barrier between the epithelial cells to what you have in the lumen. So that's all that they were showing here. So I think this is important for us to think about. And so I think I sent you all this review in the chat box links, but if not, I will. This comes from Andy Chan's group up in Boston. And so I think this is just a nice overall schematic to sort of think about the impact of diet on the GI tract. And I like this overview because they really looked at the different diets, gave a basic synopsis of the research and what some of the potential sort of etiologies are for how diet and different components cause inflammation. So when you look at Mediterranean diets, so your less processed diets, healthier whole grains, seafood, not so much your saturated fats, you find overall that you have more of a diverse microbiota. You have intact barrier function, and you really do have a balance between the tolerance that you have with immunity versus more of the pro-inflammatory components of inflammation. And when we always think about microbial diversity, I'm still reminded of sort of examples that folks used that you really want to have diversity in your microbiota in your GI tract because that allows you to be protected when there are specific secondary hits or stressors to the gut. I used to use this analogy, and this is now highly outdated, but when you looked at folks who were in businesses like Enron that had a complete and catastrophic loss financially, it's because their bank accounts, in essence, only had sort of one type of stock. So you basically didn't have any diversity. So one hit just wipes everything out. So again, just as we want diversity in our financial portfolios, we also want diversity in our microbial portfolios. But then if you look at the Western diet, again, red meat, processed foods, all those additives like the emulsifiers, higher in refined sugars, really can then impact the microbiota. You have more of that imbalance or dysbiosis. You have a breakdown in your barrier function with impaired permeability. That's one of those protective mechanisms, and that's then skews sort of the inflammatory response to one that is just much more activated. And so this is another sort of a synopsis of looking again at the different components of our diet that impact inflammation and how they do this. And this is a nice review from Ari Levine's group. So you can see the different components. So when we look at the barrier, intestinal permeability, things like emulsifiers, carrageenan, some folks feel gluten may, high saturated fat, alcohols. When we look at the mucus layer and the goblet cells, another protective mechanism, the higher fat, higher sugar diets, again, emulsifiers, and having a low fiber diet. And the thought between low fiber diets, if you have a higher soluble fiber diet, that helps with the production more of short chain fatty acids, which we know are a good nutrient source for these cells within the intestinal tract, especially your colonocytes. And so then intracellular bacterial clearance is also important because, again, you've got your commensal organisms, but when you think about inflammatory bowel diseases, it's not just about a specific pathogenic bacteria, but rather how our immune system sort of senses and then knows how to appropriately phagocytosis are clear, the commensal bacteria that it comes in contact with, and if that's impaired, then again, you have those, you have the bacteria there hanging out, so to speak, in that whole sort of milieu that leads to some of the increased inflammation secondarily. And then finally, the impact on your defenses, the proteins that you need to produce those antimicrobial peptides that are important in bacterial clearance. And so we know that diet plays an impact, especially in someone who is genetically predisposed. And we know that all diets are not created equal, that there are different components that may be protective versus more destructive or certainly inflammatory to our GI tract. And so knowing that nutrition and diet make an impact, there has been a lot of focus over the past few decades, quite frankly, predating what we have done here in the United States, especially in Europe and in Canada, really utilizing nutritional therapies for our patients who have Crohn's disease. And so I know that we all know what enteral therapy is, but just so that, again, we're sort of on the same page, especially for those who don't use it as much. Remembering that enteral nutrition or enteral therapy or EN, that just refers to the liquid formulas, which are nutritionally complete foods, to actually treat Crohn's disease for the purposes of this discussion. Whereas when we say EEN, that's the exclusive enteral nutrition, which really is utilizing enteral nutrition as the sole source. And when we talk about EEN, though, we'll say 90 to 100% of what you need for your calories to induce remission and even help maintain remission in Crohn's disease. And partial enteral nutrition is when you utilize enteral nutrition still, but it's only more of a portion in addition to regular foods. And again, in the context of specific defined diets, a specific type of sort of specific defined diet that you, again, utilize for remission, to maintain remission, or you could just be using to improve nutritional status. As we know, a lot of our children and teens with inflammatory bowel diseases often have issues with inadequate nutrition, especially when they're first diagnosed, when they're in exacerbation due to a combination of inadequate intake, increased losses, and or increased catabolic needs because of the inflammation. So there are certainly different ways that we use sort of enteral nutrition in our therapeutic sort of approaches. And so the ECHO and ESPGHAN guidelines, and I believe that a new updated guideline should be coming out in press, but they haven't really changed much in terms of how they position exclusive enteral nutrition. And so they have done the evidence-based review, they have looked at treatment algorithms and have made it clear that exclusive enteral nutrition should be the first choice for induction therapy, especially in children who have not finished growth over corticosteroids. And they also define what the poor outcomes would be, especially if you have panenteric, meaning incredibly extensive disease. So not just localized, but sort of broad scale sort of disease and encompassing a good part of the GI tract. If you have severe growth failure, more complicated forms or phenotypes of Crohn's disease with stricturing, penetrating, and perianal disease. It's not to say that you can't utilize exclusive enteral nutrition, but these are the scenarios that you probably wouldn't be using this for induction or maintenance. And the question always becomes, should you use elemental formula? Should you use polymeric formula? And if you look at all of the different sort of overviews, you know, Mary Zakos and the group at Toronto Sick Kids had looked at this over a decade ago, but the bottom line is there's no significant difference. And I think it's important to know, because when we look at elemental versus polymeric formulas, we need to think about palatability, especially if you have your patients taking it by mouth, and you need to think about cost and accessibility as well. So multiple studies predominantly from the EU and Canada throughout the few decades have looked at enteral therapy or exclusive enteral nutrition, and it really has been found to be effective in children and adults for induction and maintenance, although more effective in children than adults. And if you look at the studies, and the studies in adult patients with Crohn's disease is more limited than pediatrics, their numbers are going to be a little bit closer to 50%. For children and teens, it will be closer to 75%. But, really the take-home messages are when you look at EN versus corticosteroids and pediatric Crohn's disease, you get better remission rates, you get better mucosal healing, and you get a positive effect on growth. And those are all really crucial things that we need to think about as we sort of look at how we would position or discuss potential induction therapies with our families. But again, remembering that the efficacy has not been demonstrated in ulcerative colitis. So I'm just going to go through just one sort of more prospective study, because a lot of the studies that I showed you on the previous slide are more retrospective reviews, but this was more of a small prospective study. So a little bit under 40 kids who were either on steroids or polymeric formula. And they looked at this from a 10-week primary outcome standpoint, looking at remission as defined by the PCDAI. And what they found is that you had better clinical remission with exclusive enteral nutrition versus steroids, although you still had a good percentage of the patients who had clinical remission with corticosteroids. But the big difference was the mucosal healing. And I think this is something for us to remember, because when we look at how we care for our kids with IBD, I always like to say that you've got to get the different pieces sort of addressed. So you want your patients to feel better, obviously. You want them to have less pain. You want them to have less stools. You want them to be able to eat better, grow and gain weight. But you also want to induce sort of the deeper remission or mucosal healing. And when you look at it from that perspective, really exclusive enteral nutrition far exceeds what you see with the mucosal healing when compared to those who've been on corticosteroids. So the maintenance piece is always tougher, and so there's not as much in terms of maintenance, but this was a study from Japan that looked at adult patients with luminal, mild to moderate Crohn's disease who were in remission when the study was started. They followed up these patients for 12 months, and what they did is they allowed them to eat a healthy, traditional Japanese diet. So it's going to be less in processing and saturated fats and sugars than what we would eat here in the United States, for instance, but basically was a low-fat, traditional sort of Japanese diet during the day. And then they would get a semi-elemental formula via tube at night. And then they followed out these patients and found that the proportion of patients who stayed in remission in this one-year time frame was significantly higher when they were in the enteral nutrition group versus the sort of non-enteral nutrition group. So that was one piece. The other piece they found, just not only clinically, but endoscopically, there were lower rates of mucosal inflammation. And they also looked at mucosal pro-inflammatory cytokines, so namely TNF-alpha and interleukin-6, and those levels were lower as well. And then finally, the question of, is it better to do it orally or via nasogastric tube? I am probably by far or closest to the oldest person on this conference call right now. And I will tell you, I remember when we first started when I was a fellow, we did it solely by nasogastric tube, but I'm going to just talk about in a moment how we can utilize this orally. And, again, we felt that you just weren't going to get the compliance if you asked folks to drink it. But this study actually showed that they had very similar compliance rates, adherence rates, and remission rates, whether it was oral versus nasogastric. And regardless of how you got your exclusive enteral nutrition, you had good improvement in laboratory indices, growth, and weight gain. And then when we think about comparative effectiveness, so we know that exclusive enteral nutrition works, but how does it sort of stack up to partial and anti-TNF therapy? So this was a study from CHOP that was part of a broader study that was done in conjunction with the folks at Penn, looking at changes in the microbiota, looking at other outcomes when you look at patients who are on exclusive enteral nutrition versus anti-TNF therapies. And so this comparative effectiveness study basically looked at patients who are either on anti-TNFs, exclusive enteral nutrition, or partial enteral nutrition, and they looked at different factors, including clinical remission with the PCDAI, and you can find that there were similar rates of clinical remission on anti-TNFs and exclusive, but not partial enteral nutrition. But you had a better improvement of the calprotectin with anti-TNFs versus exclusive enteral nutrition, and certainly both groups had significantly better improvements in the calprotectin versus those who were only on partial enteral nutrition. But I want to point out that the partial enteral nutrition was not in combination with something like the CDED, but rather it was about 50% of your calories with formula, the other 50% you could eat what you wanted. But the big piece is the quality of life domain was the best with exclusive enteral nutrition with body image, but better with anti-TNFs in the emotional domain. And then one more way that you can use exclusive enteral nutrition is when you have patients who you want to optimize pre-operatively. So these are the patients who have predominantly sort of fibrotic sort of disease, who need to go through surgery. And so this was a group from China that looked at patients pre-operatively. Half were receiving exclusive enteral nutrition, the other half did not. And they did not get any other therapies for 3 months preoperatively. Not sure how we could necessarily do something like that here, but they were able to do this when they conducted the study. And the take-home messages were that there were significantly less both infectious and non-infectious complications in the patients who are on the exclusive enteral nutrition group versus the non-exclusive enteral nutrition groups, and that immediate recurrence was decreased, although when you looked at clinical recurrence rates at later time points over a 1 to 2 year time frame, they were more similar. So at least acutely, exclusive enteral nutrition does seem to make an impact before surgery. Again, a small study, but something to think about as we optimize some of our patients for more of the semi-elective type of surgeries, which I think, quite frankly, we just don't see a lot of with the severity of disease that we're seeing in a lot of our kids. But just, again, something that certainly many of us have tried utilizing. And so just for the purposes of time, as I look through this is a busy slide, but I think, just going through some thoughts on how exclusive enteral nutrition may work. And I think one of the original sort of thoughts were that it could have some efficacy on improving the diversity of the fecal sort of microbiota. But interestingly, over the past few years, when you look at the studies, it actually looks like it doesn't make an impact on the overall microbial diversity, but it may impact specific components of the microbiota that may be associated with protective factors within the microbiome, but there really isn't yet that clear-cut answer as to why exclusive enteral nutrition is being effective from a microbial diversity standpoint. However, there was one study from Dirk Heller's group over in Regensburg where they focused more on looking not so much at the microbial diversity, but looking at sort of the cytokine profiles. And so they looked at patients who had been on exclusive enteral nutrition over in Europe. And what they did is they looked at basically a panel of pro-inflammatory cytokines versus more protective. And so what I just want to sort of highlight in this very busy slide, so when you look at what are considered to be more protective cytokines like interleukin-10 and IL-4, they found that the patients who were on exclusive enteral nutrition had some upregulation of these possibly more protective sort of cytokines, but found that you had more of an increase in more of your inflammatory cytokines, or decrease rather in inflammatory cytokines, especially your TNF, when you actually went on exclusive enteral nutrition. And so again, looking at some possible sort of impact of exclusive enteral nutrition on sort of the balance of your pro and anti-inflammatory cytokines may give us some idea of why this may work, although this still doesn't give us the mechanisms completely. So, as I sort of close out the piece on exclusive enteral nutrition, I just want to go through this algorithm. And again, it's in your slides. So this, again, I just want to sort of highlight how at Nationwide Children's, the IBD team had sort of looked at how you could incorporate exclusive enteral nutrition utilizing quality improvement. And so basically, between 2013 to 2015, at the start, it was shown that the patients that we were following when I was at Nationwide Children's were really not being started on exclusive enteral nutrition for induction sort of therapy. So less than 5% were. But by developing this algorithm and being more proactive in clinic about introducing this as an option, within a 2-year time frame, it was the utilization of how this was used for newly diagnosed patients with mild to moderate inflammatory Crohn's disease went from less than 5% to just over 50%. So again, with this algorithm, it just shows how you can incorporate this, and this was all predominantly orally. Only 4 out of the 72 kids who were on exclusive enteral nutrition in that time frame received it via nasogastric tube. The rest really did receive it orally. And again, I just wanted to make sure that you guys had a copy of this algorithm so that you could look at it. And I know this is pretty much how we approach things, but you have this as a guideline. And this slide just shows how you can do a quick calculation if you decide to use exclusive enteral nutrition and you need to get this started and there's not a dietitian with whom you can immediately consult with. This just sort of shows you how you can sort of use this. And when we say standard pediatrics, we're talking about the 1.0 formulas. And when we talk about sort of the high calorie, that's the 1.5. And I just gave some examples of formulas, but again, this is not a completely exhaustive list, but just wanted to give you sort of an idea. So, we've talked about exclusive enteral nutrition, and we know that it works, but how feasible is this long term? And would people rather stay on this, or if they're given other options, would they rather use something else, specifically solid food diet alternatives? So this was a survey that was completed in one of the Scottish pediatric GI groups, where they polled the patients and their families who had been successfully treated with exclusive enteral nutrition. And almost 60% said, listen, if we needed to do another course, we would. But the majority would still have a preference for a solid food diet alternative if that was an option. And so I think that's always something that we're looking for. And that really brings us into the concepts of utilizing specific defined foods or diets for the treatment and maintenance of our patients who have inflammatory bowel disease. And so some of the diets that I'm just going to go through briefly here are a little bit about the specific carbohydrate diet, because this is really one of the original diets. I'm just going to give you some preliminary sort of data on CD treat, so you've heard about it, but then really sort of ending reviewing the Crohn's disease exclusion diet. So the specific carbohydrate diet, for those of you who may not be as familiar, is a grain-free, low sugar and low lactose diet. And the foods are really made from scratch. They're non-processed. And there are specific defined ingredients with fruits and vegetables, meats, nuts, fermented dairy, oils, and honey. And this was started by someone by the name of Elaine Gottschall decades ago, who talked about how she was able to, in essence, treat and cure her Crohn's disease by going on this defined diet. And so the folks who've been sort of at the forefront in studying this are at Seattle with David Susskind's group. And so this is a busy slide, but what I just want to highlight is that they had looked at patients with both Crohn's disease and ulcerative colitis. And you can see that they defined disease activity. So these are patients with mild to moderate disease, but predominantly mild, who had some elevation in their disease activity scores, mild elevations in their inflammatory markers, overall had fairly normal like albumin levels and vitamin D, and fairly stable BMIs, although they also had significantly elevated calprotectins. And they followed these patients out very closely over a 12-month period. And what you can see in both the patients with Crohn's disease and ulcerative colitis, that they had significant improvement in disease activity. They had significant improvement in their serum inflammatory markers. At least at the 6-month time frame, you had at least a mild to moderate sort of change in the calprotectin, and there really weren't significant changes in vitamin D. The BMIs also had not changed, at least for the patients with Crohn's disease, did go up a little bit with the patients with ulcerative colitis. But again, some of the take-home messages are that the patients did do better clinically and did have improvement to a certain extent in inflammatory markers. So this certainly was proposed as a potential component of therapies for patients with IBD. The one sort of issue, though, is that even though disease activity had improved and serum, the biochemical markers had improved, complete mucosal healing was still not induced. So I think this is not discounting it, but it is something that we have to think about if we really are trying to get patients to both feel better, but to also have healing of the mucosal lining. So, when we think about it, so you have a diet that may have some promise, but at the same time, though, it's not easy to do. And, again, how feasible is it going to be? So there was a recent study called DINE-CD that looked at the specific carbohydrate diet, so looking more at feasibility and the impact, and compared it to incorporating the Mediterranean diet, which would be, by many accounts, easier to sort of implement and complete. And what they found in this DINE-CD study is that there was both, there was similar symptomatic remission and similar sort of changes in the fecal calprotectin and the C-reactive protein, whether you were on the SCD versus the Mediterranean diet at week 6. And then if you look at week 12, if anything, even though there are no statistically significant differences between the group of patients on the Mediterranean versus the SCD, there may have actually been a better fecal calprotectin response with the Mediterranean diet. So again, more research needs to be done, but this was well conducted and comprehensive, and it really tells us that there may be other options for diets other than something that is very restrictive. So I know we're running out of time here, but I'm just going to go through CD treat just because I think this is the diet that folks are probably the most or the least likely to have heard of. This was an interesting study where there are 3 different groups. Busy slides, I'm going to explain. So group A, this was more to see proof of concept. Could you actually do this diet? And were there significant differences in the group? So what they did is they took one group with exclusive enteral nutrition, and the second group was on a regular diet that replicated all the components of what you would see in a bottle or a can of formula. So this was the proof of concept group. So healthy patients, healthy adults, not those with IBD and not kids. And so they basically wanted to see if there were any differences in terms of outcomes like fecal markers, et cetera, if you were on the CD treat versus the EN. So basically, in a way, you were on your own control. So you start with healthy individuals, and you were either on the CD treat diet or exclusive enteral nutrition. Then you went through washout where you do your routine diet, and then you flip. And then if you were in that CD treat diet group, then you went on exclusive enteral nutrition. If you were on exclusive enteral nutrition, you went on the CD treat diet. And then they looked at some outcomes and found that there are no differences. The second group was the group children who had active Crohn's disease, who they actually utilized the CD treat instead of exclusive enteral nutrition, and basically looked to see if they had clinical response and remission, and looked at some other sort of markers of inflammation. So group A, can you even do it? Are there differences between the 2 diets in healthy individuals? Group B, more of a treatment sort of group. And group C that I'm not going to talk about, but these were the rat studies to look at the differences of exclusive enteral nutrition, CD treat, and good old-fashioned rat chow to see if there were changes in inflammation, and looked at different mucosal and stool markers, so more of your mechanistic sort of study. And so what they found in that first group is that whether you are on CD treat, that diet, or the exclusive enteral nutrition, you were able to get a similar amount of calories. The adults found that it was easier to follow. They reported less GI symptoms on the diet than the exclusive enteral nutrition. And when the investigators look at the microbiome, there are no significant differences in the microbial diversity between the 2 groups. And then when they looked at the children with active Crohn's disease, they found improvement both in clinical disease activity index scores, as well as the calprotectin on the CD treat. So again, this was a very small N. More studies need to be done, but it was just interesting to look at this as a different type of defined diet. But I think, the last slides, I'm going to focus on the Crohn's disease exclusion diet. And the reason I'm going to do this is because this is what we have been utilizing here. So like the specific carbohydrate diet, it really does work on removing a lot of the things that are our process that we feel are really contributing to the inflammation that we get from dietary components in Crohn's disease. But this is a much more prescribed diet with very specific even definitions of what you need to eat, how much you need to get. So you can see the things that really are being removed and added. And again, this is just an overview of the things that you are trying to take out. So you are trying to take out your emulsifiers and additives, added sugars, saturated fats, processed meats, gluten, dairy, and animal fats. So this, again, is just a guideline. Obviously, you will consult with Stacy Zettel or our dietitians, and we do have handouts on it, but just wanted to sort of show you that this is a 12-week sort of initial phase where the first 6 weeks, it's 50-50 formula and then allowed foods, and then you start liberalizing the specific defined part of the diet by decreasing the percentage of calories from formula. And I just sort of added this Modulife sort of link. And I know Stacy's gone through the details, so I'm not going to go through too much what needs to be included on the diet, but rather going through a recent study that Ari Levine's group had published where they looked at the efficacy. And so basically, again, these were patients, children with mild to moderate Crohn's disease, non-complicated phenotypes who had been stable. And you can see that there are two groups. You are comparing, this was head-to-head exclusive enteral nutrition versus patients who are on the Crohn's disease exclusion diet for 6 weeks. And you can see that they looked at clinical parameters plus fecal and serum markers of inflammation. They also monitored for adherence. And then the second sort of phase for 6 to 12 weeks, the first group went on the 25% formula, the rest on the CD/ED. And then the second group, the exclusive enteral nutrition group, then was completely, in essence, liberalized. They were on the formula, but then the rest of their diet was just a liberalized diet. And so what the investigators found is that at week 6, you had both good compliance with both, but better compliance on the diet than actually exclusive enteral nutrition, with pretty similar clinical response and remission rates. And you can also look at our stool sort of markers for inflammation as well with the calprotectins. And you can find that you actually had better sort of decreases and maintenance of decreases in calprotectin as a GI tract specific marker for inflammation when you look at the patients that were on the CD/ED rather than exclusive enteral nutrition. So again, both showing that CD/ED is effective. It may be easier to adhere to than exclusive enteral nutrition, but may actually have an even better effect on both initial decreases, but then sustaining sort of the induction of remission in the patients. And again, busy slide, but this just looked at microbial changes and found that changes in the microbiome from weeks 0 to 12 were better sustained in patients who were on the CD/ED rather than exclusive enteral nutrition. And I see that we're at the end of the hour. So one more slide that I want to show based on some of the work that Angela Sandell did when she was a fellow here. Angela wanted to see not so much the mechanisms, but what the barriers are in terms of incorporating it. So when we talk about nutritional therapy, we know that there is a physiologic basis. We know that there's good data that shows us that different nutritional approaches in the right sort of patient subsets may be effective for induction and maintenance. But then if that's the case, why aren't we able to use it? And I think really we know that when it comes down to it, this is not always so easy. And as Angela found, the biggest barriers were really time and cost, and found that at least in our patients that we follow here, that those who are able to successfully utilize CD/ED were those who were in a higher socioeconomic status, and had greater parental education too. So you need time, you need money, and you need sort of the access to resources. So I think just to end this, so I think we hopefully agree that the impact of dietary factors on the development of IBD is certainly multifactorial. But as we think about it, thinking about ways that you can incorporate nutritional therapy in your practice. So I think certainly exclusive enteral nutrition can be used for induction and maintenance, for a select subset of children with Crohn's disease, especially those specifically with mild to moderate, that Crohn's disease exclusion diet may be effective in some of our patients with Crohn's disease, and certainly is something that would be a viable option, especially in the families who are very sort of medication adverse, especially in the right situations. And certainly you can use this adjunctively in specific scenarios, like your patients who have an abscess, patients who are going to be getting ready for surgery. And certainly you could even use this as almost combo therapy in some patients to augment their already ongoing biologic and or immunomodulator therapies. But I think, how you can make this work, I think the first thing is knowing how to market this. And so I think, as you can see, it doesn't happen overnight. So thinking about, how patient you sort of need to be. So telling folks you don't see the results overnight. It does take a little bit of time, and giving them practical tips for successful implementation. But at the same time, just as you would touch base with your families if you've started them on steroids or biologic, making sure that there are very sort of clear-cut sort of follow-up visits, either virtually, by phone, whether it's with you, your nursing staff, or our dietitians, to make sure that things are not only going smoothly from an implementation standpoint, but also from a clinical standpoint as well. So, and I apologize that we're probably not going to have time to go through these questions due to the technical sort of difficulties that I ran into with the late start. But I just want folks to sort of think about some of the questions that I broached before, as you think about how you can sort of best incorporate sort of nutritional therapy in your practice. So if anybody has any burning questions for the next couple of minutes, I'm happy to take them. But if not, please don't hesitate to hunt me down. I'm happy to answer any questions. And again, I have included a full copy of my slides, so you have them, as well as some articles that might be helpful. So thanks for your time and your patience. Any questions?
Thanks, Sandy.
All right.
I have one
Thanks,
question.
Sandy. That was wonderful.
Can you hear me?
Hello?
Hi, can you hear me?
All right. Yes, I can. Yes.
Oh, I just had one question for you. I think we talked about this before, but how do you, when a lot of times families ask, okay, we're talking about, I think you're gonna know where I'm going with this. We're talking about limiting emulsifiers and additives from our diet, and then you tell me to drink Boost. When I look at the ingredients, I see all of those things in it. So how do you navigate that conversation?
I tell them you're absolutely correct. You're correct, but the data is still very clear that exclusive enteral nutrition with our existing formulas is highly effective. It does work. And it still is a better option than things like corticosteroids. But I also tell them that, if we think that exclusive enteral nutrition works in its current form with our formulas, it would be great to know if we had sort of formula options that didn't have quite these additives and emulsifiers. It may be even more effective. And there certainly are gastroenterologists that are researching exactly that. So if you had basically formulas that you could make that are much more consistent with a less processed diet, like an SED-like diet, for instance. So I know, for instance, in Seattle, Dale Lee has been looking at this. That would be even great in the future. The problem is with formulas too, we can't completely strip all of those things out, because otherwise it wouldn't be portable. It wouldn't be sustainable, because you can't have a formula that you just make up fresh without all those items. So there's a practical standpoint, but again, it works. So I think that's important. Folks are looking at sort of making your own formula that is much more reflective of a less processed diet. And we do have some options currently, something, for instance, like Kate Farms, and I am not giving a plug for one product or another, that may not have quite as much of those additives, and that is why we are using it more actively. All right.
Maybe can I ask one quick question?
Sure,
Well,
ask away.
It may not be that quick, but I'd love to hear your take on it. You know, the whole idea that the patients that or especially in Angela's study that seem to be participating in diet therapy are these kind of higher socioeconomic status group. I guess the big question is, how do you think we address that disparity? I guess the smaller question is, how much of a role do you think, you know, the physician bias and patient selection plays in that?
I think there most likely is an unconscious bias. So how the patients are approached, because I do think that we, one way or the other, sort of say, well, I bet this family would be more amenable to doing this. But I think one of the ways that we have evened out that bias a little bit, and this is actually a shout out to Whitney, is I think by having a consistent person who does the new IBD patient teachings. I know for a fact, and Whitney, you can give me the thumbs up or tell me if this is the case, that in the patients where we think at least nutritional therapy is an option, I know that she does broach that with everybody, so that at least evens out some of that bias. And am I correct, Whitney, with that?
Yep, they're all made aware of the different diets,
Right.
and I give them a handout that kind of summarizes them.
So I think that's a great question. I think that's so at least one piece that we take out that bias, hopefully, at least for the purposes of our center. But I think the broader question of accessibility, I think it is absolutely an issue, because I mean, formula is expensive, guys. If you start calculating out how much it costs, it can be $1,000+ And I mean, so just to give you an idea, 12 bottles of Kate Farms is $48. Start doing your math pretty quickly. You guys are pretty bright. There are 30 days in a month. That adds up incredibly quickly. And so I think this is a broader scale, and it's a plug for advocacy. Certainly the Medical Nutrition Equity Access Act has a defined group of diseases. Inflammatory bowel diseases are one. Many of our other pediatric-based diseases are another. Trying to get this sort of covered so that at least the that cost isn't going to be prohibitive, because a lot of families can't afford to get the formulas. What we do have that may help, ironically enough, is if you are on the wraparound Medicaid-based plan, that does cover formula. The problem is most of the commercial entrances don't. So for your patients with IBD and other sort of chronic illnesses, getting them on that wraparound plan, at least for our state, is important, because formula will be covered through at least that wraparound. But the bigger thing is with CD/ED is the cost and the time of making the meals. I have actually had patients, families who've told me the amount of time, you're looking at an entire Sunday of prep for a lot of these families for the week. And so if you are not in a two-income, two-parent household, this does become very difficult. And I think at least we do have some of the resources with the Modulife, so that's made it better, but I think that's easier. And then the final piece is the food insecurities piece. And again, in fact, we have a few patients. I had a patient who in clinic who said, I want to eat healthy, but as she screened positive on the food insecurity screen. And so we've been looking through resources, but you know what? Food banks don't traditionally give you access to a lot of these foods that are healthier. I will tell you, we don't have it here at UPMC, but I do know that if you have an Allegheny Health Network provider, again, you know, a group of us, we're looking at nutritional resources. They do have like a healthy nutrition type of food bank that if you have an AHN provider and they refer you to this food bank, you meet with the dietitian, and I think at least there's some counseling providing sort of healthier food items. So that's not a perfect situation. More has to change, and I agree with you, Vic, on this. But there are some of those resources, but I think it's also all of us trying to stay sort of ahead of this. And I know that Mary Ayers has been sort of our food insecurities sort of contact person, and I know that she has sent out resources. So making yourself well-versed in the resources, in the entrance options, and And, and again, and being willing, I guess, to see if we can push our insurance companies a little bit more. I know that some of us we're very vocal about that, but continuing that fight. I always say fight for these formulas just as much as I fight for getting the right biologic dose to patients, but that's another discussion. So.
Thanks.
All right. So again, guys, I know that I threw a lot of information. Again, I'm happy if you guys have questions individually offline. Please don't hesitate to hunt me down. All right. Well, you guys have a great weekend.